Hi, everyone, and welcome to our virtual health event with UC Health. My name is Hannah Strepfer, and I'm the Senior Event Coordinator here with the Highlands Ranch Community Association. We are so excited that you took the time out of your evenings to join us to discuss hip and knee arthritis. We are grateful for UC Health Highlands Ranch Hospital as a community partner and happy to host this wonderful event with their assistance. Before we get started, I would like to go over a few housekeeping items. We are recording the webinar this evening and will be sending out the recording via email by the end of the week. During the webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box located either on the bottom or the top of your screen. We will try to save the questions for the Q&A portion towards the end of the event. Our presenter this evening is Dr. Koonce. He is an orthopedic surgeon specializing in hip replacement and knee replacement from UC Health. Now, without further ado, I'll pass the time off to Dr. Koonce.
Okay, thanks so much, Hannah. Really appreciate the opportunity to speak with you all. I work in Highlands Ranch. I live in Lone Tree, so we are neighbors, and it's just really an honor and privilege to be able to talk to you about what I do every day. So we're going to talk about hip and knee arthritis diagnosis and treatment. So let's dive into it. So I want to give you a little bit of my background, just so you know where I'm coming from, and as I go through what I do every day professionally. So I grew up in Montrose, Colorado. I'm a Colorado native. I went to medical school at the University of Colorado and did my orthopedic surgery residency there. I did 2 fellowships, which is additional training beyond the standard orthopedic surgery residency. One in sports medicine, and then one in adult hip and knee reconstruction. And that second one will be what's relevant to the talk today. I practiced for 2 years in Washington State before moving back home to Colorado. I've worked at Kaiser and Lone Tree for 5 years, and I've now been with the University of Colorado for 3 years on faculty at the School of Medicine, working full-time out of Highlands Ranch Hospital. So Highlands Ranch Hospital off Lucent Boulevard has been open for about 3.5 years now. We offer orthopedic services in hip and knee replacements, which is what I do, shoulder and elbow care, foot and ankle, spine, hand, and trauma. So we have a wide array of orthopedic surgery services we offer through all providers that are specialists within those different categories. And my practice is 100% hip and knee replacements. I no longer do sports medicine. I do over 500 hip and knee replacements a year. Things that we offer include minimally invasive anterior hip replacement surgeries. That's one of the surgeries we're really proud of. We teach residents and fellows. I do some research, and then I also teach some other practicing surgeons about what we do and teach them some of these procedures. So let's go over today's game plan. First, I want to go over just some very basic hip and knee anatomy that's going to be relevant to the rest of the talk. We're going to talk about what exactly is arthritis. How is it diagnosed? What are the non-surgical treatments for arthritis? And then what are the surgical treatments that are available? So starting out with the anatomy portion. So this is, again, very basic, but this is all we really need for this talk. The knee has 3 relevant bones: the femur, which is the longest bone in the body, that's your thigh bone, the patella, which is your kneecap, and then the tibia, which is your shin bone. So this is kind of an oblique view. The knee is kind of facing to the side with the kneecap out there in front. If we look inside the knee, so this is the patella on the left side, the kneecap flipped out to the side. There's 2 relevant cartilage surfaces in there. One is the surface cartilage within the knee joint, which is a smooth surface that cushions the joint. And then the meniscus, which is a C-shaped fibrocartilage disc that sits on both sides of the knee. We'll get into both of those a little bit more. Jumping to the hip is a ball and socket joint, which is different from the knee, where the knee is a hinge joint. This is a ball and socket. And so the relevant bones here are the pelvis and the femur. Those are the 2 bones that make up the hip joint. If we look inside that ball and socket joint, we see the acetabulum, which is the socket of the joint. We again have smooth surface cartilage, And then we have the femoral head, which is the ball part of the ball and socket joint. And the femoral head is just the top of the femur bone. So the first really relevant question here today is, what is arthritis? If we break down the word arthritis, this is actually formed from Greek words. So arthron means joint and itis means inflamed. So really what this means is inflamed joint. Inflamed joints are often accompanied by swelling, pain, and stiffness. And an important point here is that arthritis is not a substance, it's a condition. I'm often asked by patients, are you going to go into my joint and clean out the arthritis? And the answer is that's not possible, because what we're talking about is a condition, or actually a disease, that's called arthritis. It's not something that we can clean out. And in my world, what we really mean when we say arthritis, it just is very simple. It's just worn cartilage. So if we go back to the knee joint and we look at that smooth surface cartilage on the left, we see on the right part of the screen that this shows cartilage wear and inflammation. So that is the condition that we know that we call arthritis. And so note that in knees with worn surface cartilage, the meniscus that I mentioned, the C-shaped disc, is nearly always torn and is considered a secondary problem. So if you have a knee that has arthritis, I can almost guarantee the meniscus is torn, but the meniscus we worry about less, and we treat the arthritis itself, the worn surface cartilage itself. So what joints does arthritis affect? Well, it can be any joint in the body. Adult humans have over 200 joints, but the most commonly affected joints are hip, knee, shoulder, hands, wrists, neck, spine, foot, ankles, toes, and elbow. But the ones that are relevant to today's talk are going to be hip and knee. These are the only two that I really have a lot of expertise in, and that's what we're going to focus on. So let's talk about 3 different types of arthritis. The first is osteoarthritis. So this is the most common. It's wear and tear type arthritis. We'll talk about the specifics of it in a minute. The second one is inflammatory arthritis. So think rheumatoid arthritis, and this is a condition that's often treated by rheumatologists. So if you have inflammatory arthritis, you've probably seen a rheumatologist for a consultation. And then the last one is post-traumatic arthritis, which, for example, is prior trauma to the knee that causes damage to the surface cartilage. So talking about the most common type, osteoarthritis, most adults will get pain from hip or knee arthritis in their lifetime. This is what we call wear and tear arthritis. The cartilage wears out over time with use or injury. The causes are multifactorial, meaning it comes from many different things, including genetic causes. You can inherit this from your parents, past injury, luck. In some cases, it's not completely understood, so that's why we call it luck. But in general, there's many causes, and it's hard to often pinpoint what exactly caused it. Let's talk about the progression of osteoarthritis. So I want you to pay attention to the X-ray on the right side of the screen that's a knee. And I want you to look at the space between those two bones, the femur and the tibia that we talked about. Cartilage does not show up on X-ray, so it shows up as a space. So in the beginning stages of osteoarthritis, you may have no symptoms, but the signs of the disease may be seen on X-ray. And most people over age 60 show some signs of arthritis on X-ray, but only about a third of them have symptoms. As we progress, notice again on the screen on the right, that space where the cartilage was is now narrowed. So the surface of the smooth cartilage covering the joint becomes rough. That space narrows on X-ray, and the cartilage begins to lose its ability to absorb the impact of movement, and it's now more easily damaged from excess use or injury. And those bones at the end of the femur and tibia have a lot of nerve endings, so this is accompanied by pain. Again, referring to the X-ray now, if we see the severe form of arthritis, you can see that cartilage space is completely gone. And in this scenario, large sections of cartilage on the surface may wear away completely with time, and the joint loses its normal shape as the cartilage breaks down. So in severe knee arthritis, we may also have bone growths or spurs that we call osteophytes that are circled here in white. It's kind of hard to see. It's small on my screen, at least. But these form when bone rubs against bone, and it's a radiographic feature and not a problem in and of itself. Moving to the hip joint, we'll move up the femur, up to the ball and socket joint. We see on the left a normal hip joint, and then on the right an osteoarthritic hip joint where you see rough surfaces, again, similar to the knee. So a big question is, what causes osteoarthritis in some people and in some joints, but not others? Or a question I get a lot is, why do I have this in my right knee or right hip, but not my left? And we don't always know for sure. Again, it's multifactorial. But what we are sure about is risk factors. So let's talk about a few of those. So risk factors for osteoarthritis. Number one, older age. The older we get, the higher our chance of having arthritis. Gender, women, it happens more often than men. Bone deformities. Some people are born with malformed joints or defective cartilage, and that increases the risk. Joint injuries, which we can get to in a minute with post-traumatic arthritis. Obesity, carrying more body weight places more stress on your weight-bearing joints, such as your hips and knees. And there's actually some interesting research that's coming out. I saw a talk last week talking about how excess body weight actually causes an inflammatory state in the body, which contributes to the formation of arthritis, completely separate from the extra weight that these joints are seeing. Sedentary lifestyle. Cartilage depends on joint use for its nutrition. And then genes, you inherit these from your parents and you can't change them. So if we start talking about how can we prevent arthritis, we start talking about which of these things can we treat, or which of these things are what we call modifiable risk factors. Well, we can't change our age. We can't change our genetic gender. We can't necessarily change bone deformities that we have. If we're injured, we can't go back and change that from the past. And we can't change the genes that our parents gave us. So that really leaves us with excess body weight and sedentary lifestyle. So the important point here is, if we're going to prevent arthritis, we want to keep our body weight as close to ideal as possible, and we want to remain active. So if we start talking about symptoms, the main symptom of osteoarthritis is pain. It's also accompanied by stiffness, activity changes, gait changes, and maybe even sleep disruption in severe cases. When we're diagnosing osteoarthritis, we suspect it based on symptoms in age, and it's confirmed with an X-ray. And an important point here, a question I'm asked a lot is, do we need an MRI or CT scan to really get to the bottom of this? And it's usually not necessary. Those studies are reserved for when we don't have a diagnosis. If we have a diagnosis on X-ray, I rarely need an MRI, CT scan, or lab test to prove what the diagnosis is. Post-traumatic arthritis is an injury to a joint where the cartilage is damaged, and once it's damaged, it's actually difficult to repair, and then the joint wears out faster. And unlike osteoarthritis, we know the cause. So the X-ray shown on the screen shows what we call a tibial plateau fracture, which is a fracture at the very top part of the tibia or shin bone. This is fixed in this case with plates and screws, but that cartilage remains damaged. And in the future, we see narrowing of that cartilage space. And so this patient has post-traumatic arthritis. So what is rheumatoid arthritis? Well, this is a different cause of cartilage, where it's an autoimmune disease, which means the body is attacking its own healthy cells and tissues. This causes pain, swelling, stiffness, loss of function, and over time, it can cause damage to the joints. So this is usually confirmed with lab tests which are ordered by a rheumatologist. I don't consider myself an expert in rheumatoid arthritis or other inflammatory arthritis. Really, the rheumatologists are the experts in that. And so let's move on to, once we have arthritis by any of these conditions, what are the non-surgical treatment options in the hip and knee? So number one, exercise. Keep those joints moving. So low impact exercise is better once we have a diagnosis of arthritis. So we're talking things like yoga, walking, elliptical trainer, bicycle, swimming, things that don't put a lot of impact on the joints when we move. High impact exercise like running, high impact aerobics, and basketball put a lot more stress on the joints. Now, there is some interesting research that's come out in the last several years showing that that high impact exercise is not necessarily a cause of this. But once you have arthritis, we recommend against it because we think it can accelerate it. So this is a no, or at least try to avoid once you have this diagnosis and pain in a joint. Physical therapy is a great non-surgical treatment option. We see via multiple studies that if muscles are strengthened around joints with arthritis, they tend to hurt less. I've experienced this in my own knee. Physical therapists are great coaches to increasing activity. And in my experience, physical therapy is more effective for treating arthritis in the knee than in the hip. Medications are also an option. The commonly used ones are just over-the-counter Tylenol or non-steroidal anti-inflammatory drugs, also called NSAIDs. The common ones are ibuprofen, which is Advil or Motrin, or naproxen, which is Aleve. And many medications used to treat arthritis have side effects, so these need to be discussed with your healthcare providers and base them on your other medical conditions. Opioid pain medications, things like codeine, oxycodone, hydrocodone, morphine, etc., is something that I think is worth discussing. And this is, in my book, a no-no for any type of arthritis pain. The United States has 4.4% of the world's population, and we consume over 80% of the world's opioids. So this is a crisis in the United States. It's not recommended for treatment of arthritis by the FDA or the American Academy of Orthopedic Surgeons. There are many side effects. They have high addictive potential, and in the long term, you can get something called opioid-induced hyperalgesia that makes all of your joints hurt more, not less. So I strongly recommend against them as a primary treatment. Corticosteroid injections are a good treatment for some people. I think they can safely be given up to 4 times per year in any one joint. They provide a strong anti-inflammatory effect within the joint. They don't solve the problem. They don't change the x-rays, but they can allow patients to be more active and therefore decrease long-term pain. The duration of effect can be variable. Some patients, it's a minimal, a few days, maybe a few weeks. Some it lasts months. I don't think there's a lot of downsides. Steroid injections get a lot of bad press, but it's worth noting that there are no clinical studies showing that this breaks down cartilage. There are some laboratory studies that show that it might have effect, so that it gets some bad press, but I think it is a safe treatment option. Hyaluronic acid injections are something that are out there. This is a naturally occurring substance in the joint. It works, in my experience, in some research, on about 50% of patients, so that's important to understand. Not every insurance company covers it, but many do. If it works, it can provide relief for months, and in my experience, it's partial relief of pain, especially in more severe conditions. It's usually not total relief. I think that topical treatments on the skin are also good. I think they're all low risk, so they can help. If they help, you should use them. You should note that they don't have great scientific evidence behind them and provide short-term relief. So this is things like Voltaren gel, which is diclofenac gel, now available over the counter, Icy Hot Biofreeze, capsaicin cream, Tiger Balm, ice packs and ice machines, heat pads, showers, baths, knee braces, and KT tape would all fall under this category. There are some treatments lacking scientific evidence for arthritis. So glucosamine and chondroitin is a very common supplement used, but there is not good data showing that first of all, there's no data showing that it protects cartilage. There's not great data compared to placebo showing that it's good for treating arthritis pain. I do know people that in patients that claim that say that this works, but the scientific studies just haven't shown a great effect. Acupuncture, massage, chiropractic treatments, and stem cell injections all have minimal scientific data showing that they can provide any long-term relief. Stem cell injections are worth mentioning, and what I tell patients are that there's a huge disparity between the advertising that happens behind stem cells and the actual scientific evidence. None of them are covered by insurance, the advertising can be misleading, and there's no scientific studies showing that they regrow cartilage in any way. So I think that's important to note because I see advertisements for them all the time. So now we're going to move into surgical solutions for arthritis. And as a surgeon, this is the part that excites me. The first question, though, is what about arthroscopy? This is the scope procedure. This is inserting camera and instruments through small incisions in the front of the knee, for example. And historically, maybe even dating back 20 or 30 years, this has been used to clean out the joint, even in an arthritic joint. But the more recent studies show questionable benefit in anything but the mildest forms of arthritis. And it's primarily used to treat meniscus tears without arthritis. So I have partners that do this surgery. I no longer perform this, but if anybody in the audience has a meniscus tear without arthritis, I would certainly be happy to provide a referral to some great doctors who perform this procedure. The first procedure that I do on knees is a partial knee replacement. So this is what we call a unicompartmental knee replacement. It's 20% of patients have cartilage wear in just one part of the knee. This is the only time that this works, is if only one part of the knee has wear. I think that the advantages are that it feels a little more natural than a full knee replacement. The recovery is just slightly easier, but the risk is that other parts of the knee can wear out later. So this is a graphic showing what happens. On the left, we see an arthritic knee, and then the right picture there shows the femur and tibia surfaces taken out during surgery. These are the components that are inserted into the knee for the femur and tibia. And then what we end up with is just that one side of the knee replaced and the rest of the knee left alone with the patient's regular cartilage and anatomy. This is different than a total knee replacement. So a total knee replacement is the most common procedure that I perform. I do about 300 of these a year. On the left picture shows an arthritic knee, which we've seen on prior images. This shows the cuts that are made on the femur and tibia to insert the metal and plastic pieces that form the knee replacement. These are what the implant components look like. And this is how they look when they're inserted. So this is really a knee resurfacing. We're not cutting out and removing the entire joint. We're just resurfacing the ends of the bone. So I think a more accurate name is a total knee resurfacing, not a total knee replacement, but nonetheless, the name is total knee replacement. I'm going to try and show a quick video here. This is not graphic in any way of what happens during a knee replacement. So this is showing the joint is opened up through a skin incision, and the knee is exposed. The patella of the kneecap is moved out of the way, and you can see the rough surfaces inside the knee joint. Those surfaces are then removed from the joint, from the femur, and then on the tibia side there, and also behind the kneecap in most cases. So this is where the surfaces are prepared for these components. This is the femoral component, the tibial component, and then the patellar component. So these will then be inserted into the knee, usually with a special orthopedic glue. And then you see the new surfaces there, and then the knee capsule and skin are then closed, usually with sutures that are absorbable, and we use a skin glue to leave a nice thin scar on the front of the knee. So after surgery, most patients stay in the hospital anywhere from 0 to 1 night. Some people will stay longer, but most commonly we're sending people either home the same day of surgery or they stay 1 night, depending on past medical history. The first 2 weeks are not easy, and I try and be very transparent with patients about this and try and prepare them for it. By 6 weeks, I expect people to be back to most everyday activities, but not pain-free. And at 6 to 12 months, was when we see all of the pain and swelling go away. So we say that this is a 1-year recovery. Let's move into surgical solutions for hip arthritis. So the only procedure that I perform for hip arthritis is a total hip replacement. So this shows a normal hip, and then what we do is we remove the ball from the top of the femur. We remove the femoral head. We insert the femoral prosthesis, which is a stem and ball. And then we also, on the acetabular side, the socket part of the ball and socket side, the socket side of the ball and socket joint, we put a cup with a liner in it. And then you can see on the picture on the far right that there's a new ball and socket joint. So again, I've got another video that shows kind of in cartoon fashion what this looks like. So I use the direct anterior approach to the hip, which is an incision kind of in the front, slightly to the side of the hip, compared to the traditional posterior approach, which is a longer incision in the back. We again go through the skin and we spread muscles apart. This is a minimally invasive approach, so we don't cut muscles. We go through the different muscle planes. We expose the hip capsule and we see the arthritic joint here. Again, worn cartilage surfaces is what we're looking at. We prepare the socket part of the joint with a special tool called a reamer to accept the acetabular cup. That cup is inserted with a liner. Orthopedic glue of any type is not usually used to keep that in place. It's press fit into place. We remove the head of the femur from the femoral side. We prepare the femoral canal, which is hollow. And then we insert the femoral prosthesis down inside that hollow femur bone. Sorry, we're a little laggy here. There we go. And then the And then we have a new ball and socket joint, which it does a great job of removing pain. And then we close, the muscles slide back together, and then we close the skin again with typically absorbable sutures and skin glue. Sorry, my slides are jumping around a bit here. So an important question that I get all the time is, how long will a joint replacement last? Well, the recent data shows 20 to 30 years, sometimes in excess of 30 years. So this has been growing over time. And I think that's really good data, because typically we tell patients, if you're in your 60s or 70s, this is likely to last you the rest of your lifetime. But I think that there are many reasons to do it earlier than 60s and 70s if you have a very painful joint that's limiting your ability to be active. Another common question I get: when is the right time to get a joint replacement? Well, in my practice, there are 4 criteria to qualify. You need to have arthritis that's at least moderate or severe on x-ray. Mild arthritis is not enough, because we have some studies that show that mild arthritis increases patients' risk of dissatisfaction with the outcome. I want patients to have tried some other things. Jumping right into joint replacement surgery, which is a big surgery right away, is often not the best idea. We like to try some other things and see if they work, that are a little less risky and less of an undertaking for the patients. We want patients to be healthy enough for surgery, of course. And then the subjective part that I can't determine on x-rays or any other way is that patients need to have daily life-limiting pain. So this is a discussion between surgeons and the patients they're treating as to how much pain they're having. And then based on those 4 criteria, we can usually make a decision. So kind of wrapping things up here. So first of all, just with some take-home messages. So number 1, we always start with non-surgical treatment options. I think that the therapy, injections, medication, exercise, and/or physical therapy, and weight loss are a great place to start. Number 2, I don't want to harp on this, but I think it's important. I believe in weight loss for treatment of arthritis. For overweight patients, nothing will help joint pain more than weight loss. I think this is zero risk and all gain. Patients can have improved overall health from this. This can be a life-changing and sometimes life-saving decision for our patients. I've had some patients that come in for joint replacement surgery, and we ask them to lose weight ahead of time, and they go through a weight loss program, and they'll come back on occasion and say, I no longer want to have my joint replaced because my knee or hip pain has gone away. And then the benefit of this is, if it does not take away the joint pain, if you can get to your ideal weight or closer to it, surgery is actually much safer if you do end up needing that. And number 3, not all types of arthritis are the same. Osteoarthritis and rheumatoid arthritis are different in their etiology. Osteoarthritis, orthopedic surgeons and even primary care doctors are good at treating. If you have rheumatoid arthritis or one of these other inflammatory conditions, a rheumatologist is the best place to start. And then, the treatment is also very different. So it's important to figure out what time you have or what type you have, and primary care doctors or an orthopedic surgeon can help you out with that. Number 4, joint replacement surgery works in the right patients. So talking about outcomes, more than 85% of patients are happy with their knee replacement. That number goes slightly up for hip replacements to about 90% or more. There was an article that came out in the Lancet around year 2000 that called hip replacement the operation of the century because of the success and patient satisfaction rates. And one thing I hear from patients all the time, I heard it more than once today in my clinic, is I should have done this sooner. So if you have arthritis and a painful joint that's affecting your quality of life, this can be a great option. Number 5 is that surgery has risks, and we work hard to minimize risks with surgery, but it's not zero. General health is always evaluated prior to surgery to maximize outcome, and every patient has a different risk profile. So one of the things we take a lot of pride in at UCHealth and at Highlands Ranch Hospital in particular is that if you're considering a joint replacement, we look at all of your individual risk factors. And if you're no matter where you're having this procedure done, you should discuss potential complications with your surgeon. So, and the last thing is, if your hip or knee is hurting, we can help. At Highlands Ranch Hospital, like I mentioned, we cover most subspecialties of orthopedics. All of our surgeons are fellowship trained, which means we're subspecialists in the type of surgeries that we perform. This can be cumbersome from a an appointment standpoint, because a lot of times patients want us to see multiple joints for different things, but because we're so specialized, we all have our niches, and that has a lot of advantages when it comes to treatment, especially surgical treatments. We all follow evidence-based practices, and we're at the forefront of teaching and research. We follow patient-centered protocols, meaning there's no one treatment for everybody. We want to tailor treatment to what you need. And then we have a very robust outpatient hip and knee replacement program if you qualify. The last thing I want to mention is that we take a lot of pride in our patient education at the University of Colorado. For anybody having joint replacement, I think we do this better than anybody in the state. We've developed programs that are novel to do this. It's a cornerstone of joint replacement surgery. We offer a program called Ortho School that we developed that's online classes to prepare patients for surgery, where you learn about the risks, benefits, and recovery recommendations. I give a bound book to anybody that's signing up for a joint replacement that comes to my office, and we sign up for a joint replacement, so that people that want to read about this can learn about the whole process of arthritis, the surgery, and the recovery ahead of time. And we find that informed patients are happier with not only their joint replacement, but just the process in general. So thank you very much for your time. I never pass up the opportunity to show a captive audience pictures of my kids. So there they are. I've put my website, Ryan Koonce MD, on there. And then also our appointment line is on there if anybody's interested in meeting with us. So with that being said, I'd like to turn it over to Hannah to answer, or she'll go through any questions that we have. I'd be happy to do that.
Great, thank you, Dr. Koonce. And yes, now is the time for our Q&A. So if you have any questions, please type them into our Q&A chat box. And I do see we already have a few. The first question I have for you is, platelet replacement therapy has worked for me, but the cost has been excessive for putting my white blood cells back in, and our insurance does not pay. Relief lasted for about 3 months. What are your thoughts?
So I think what's being referred to here is PRP, or platelet-rich plasma therapy, which is where we take a blood draw from a patient, spin out the platelets and plasma, and inject it back into a joint. I didn't mention that specifically, so the data on that is about on par with the hyaluronic acid that I mentioned. I think that there's some data that shows symptomatic relief in hip and knee arthritis. So I would say it's maybe a coin flip as to whether it would help people. As far as I know, there are no insurance companies that pay for this. Insurance companies, including Medicare, make decisions on treatments based on data. And I think what they're saying is, we don't think there's quite enough data on this to support it. But a lot of patients do get this treatment. I support this much more than stem cell therapy, because the data is much better and the cost is about 1/5 the cost of stem cells. So I do think it's a viable treatment. It's unfortunate that insurance companies aren't paying for it. You know, that is one treatment that I support. So thanks for that question.
Great, thank you. And the next question we have is, who do you recommend for meniscal tears?
We have a lot of great, in orthopedics, the meniscus tears, we refer to our sports medicine group. We have a lot of great sports medicine surgeons in our group that span from Boulder up at the Champion Center in Boulder, at our main campus, at the Colorado Center, which is at I-25 in Colorado. The closest one to Highlands Ranch is the Steadman Hawkins Clinic, and I'm in the same group as them. They've got great sports medicine surgeons that treat meniscus tears. I can't pick one that I would say I would go to. I would endorse everybody in that group, but I would say most commonly, based on location and just in expertise, I refer patients to the Steadman Hawkins Clinic.
Great, thank you. Next question. I had my right knee TKA over a year ago. Why would the knee creak so loudly when getting up? What can be done? Also, the joint continues to have slight to moderate fluid swelling. Is that typical?
You know, it's a good general question. It's one of these things that we'd have to look at very, specific things to come up with a diagnosis there. But I'll give you my general thoughts on those questions. So a little bit of noise in knees, and I was just talking to a patient about this in clinic today. Noise in both native and replaced knees, a little bit of creaking or crackling can be considered normal. If it's painful noises, that can be a different story. But if it's painless noises, we generally tell patients don't worry about it, because that's just part of the way the joint is constructed, and I don't get too concerned about that. There's a subset of patients that have knee replacement that can retain a little fluid in the knee afterward, and that can be normal. There are some situations where it's not, but in general, we always start with, is the knee painful, and are these conditions associated with pain? And if they are, there are different things in the workup we can do to try and figure out what the cause is. But I think, to just get back to your question, the answer would be, yeah, in some people, I do have some patients that are doing very well with their knee replacements, but they continue to retain some fluid. And I think that can, in some cases, be a normal finding. I wish we knew the cause of that. I wish we knew more about everything in medicine. This is one of those things that we don't know why some patients retain a little fluid and some don't.
Great, thank you. Next question we have is, what happens when the hip replacement wears out?
That's a good question. And, the good news is it's really uncommon. So especially if the hip replacement is done after the year 2000, when the plastic piece in the cup, the acetabular cup, that plastic piece that we showed in the video and pictures, is made of polyethylene. They changed the way the polyethylene was formed after about the year 2000 to what's called highly cross-linked polyethylene. And in fact, it's very rare that we see that wear out. I would say I do, I see a lot of patients for second opinions or hips that have been done 20, even 30 years ago. Probably twice a year do I do a surgery for worn out parts and pieces within the hip. So if depending on where it's worn out, if it's that plastic piece, it's a relatively, surgery is never easy, but compared to other surgeries, it's a relatively easy surgery to change out that one piece. But again, it's quite rare.
Great, thank you. Next question, is robotic surgery with 3D imaging more successful than traditional total knee replacement surgery?
That is a question that I'm asked almost every day. And so I'll try and give you my unbiased answer to that. Robotics has come a long way in surgery, particularly in general surgery, urology, things like prostate surgery. In orthopedics, as of now, there's been lots of studies on this, and it's showing a couple of things. One is that the surgery costs more. The second is that the surgery takes more time. And the third is there's no change in long-term outcomes. There are some studies in robotic surgery that show more accurate placement of components. But when you compare an experienced surgeon using traditional instruments to robotic surgery, there's no difference in outcomes. I'm interested in robotic surgery because we are a teaching hospital, and I have residents and fellows who I think that this is the future. Maybe in the next 10 to 15 years, we're going to see a shift this direction. So I'm interested in that, and we are discussing with our hospital whether or not we should get a robot and start doing joint replacement with it. But I want to be clear, but I'm very open with the hospital and with my patients that I don't have data to say that I can do your joint replacement better, or you're going to have a longer lasting joint or a better outcome because it's done that way.
Great, thank you. Next question, does osteoarthritis include inflammation, or is all inflammation rheumatoid arthritis?
No, that's a good question, and I may not have been totally clear on that. So all arthritis has some inflammatory component, and pain and inflammation go together. So any type of arthritis, the itis part of arthritis is the Greek word for inflammation. So any type of arthritis has an inflammatory component. The rheumatoid version of arthritis or other rheumatoid type diseases actually have a process where the body's attacking the normal cells in some way. And so I think there's more inflammation with that, but every type of arthritis has an inflammatory component.
Great, thank you. Next question. Do replacement knees have as much mobility as natural knees?
So it depends. If you're comparing a native knee that has no arthritis, it's likely to have more range of motion than an arthritic knee, which will have about the same range of motion as a replaced knee. So one of the predictors of range of motion after knee replacement surgery is preoperative range of motion. And we see with arthritic knees that one of the symptoms that we discussed in the talk was that they can be stiff. Now, that doesn't mean you can't improve it some, but a normal knee range of motion is somewhere around 0 to 140-ish degrees. A patient that comes in that has that range of motion before a knee replacement is more likely to achieve a higher range of motion after surgery than a patient that shows up in our office that has, say, 100 degrees of motion in that knee. So in general, I would say more because of the pre-existing arthritic process, the knee became stiff, and that's the soft tissues becoming stiff. It's a lot of work to try and get that stiffness out even after the knee replacement. So on average, I would say the replaced knee has slightly less motion than a normal native knee, but our goal is to get patients to a very functional range of motion where you can do things like get up from a low-seated chair, ride a bike, squat down to the floor comfortably, things like that. So our goal is functional range of motion. And my goal for my patients is somewhere around 0 to 120 degrees. And that, again, depends a little bit on their preoperative range of motion.
Great, thank you. Next question. What are your thoughts on collagen supplements to take for tissue care?
So from a joint standpoint, a joint, cartilage, meniscus, tendons, ligaments type thing, I'm not aware of any data that shows that is effective for relieving arthritis symptoms or things like that. I'm going to take off my orthopedic surgeon hat for a second and put on my kind of triathlete and cyclist hat, which is something I do recreationally. And I have seen some studies in that world where taking collagen peptide supplements can have some benefit in runners not, I wouldn't say protecting soft tissues, but maybe avoiding pain and in some cases injury with running specifically. That's about the extent of my knowledge there. I can't claim to be an expert on that, but I know that there are some studies looking specifically at collagen peptides supplementation for endurance athletes.
Great, thank you. Next question. Have you ever had any patients with a bone cyst on the head of the femur?
So there are kind of 4 radiographic signs of arthritis on X-ray that when we're taught how to look at X-rays, we look at. And one of those features is what's called subchondral cysts. So we can see bone cysts in the knee and in the hip, and very, very regularly. So especially patients with more severe forms of arthritis, one of the things that happens is that cysts can form in the femoral head. And so, yes, that's very common.
Great, thank you. And next question, is there a benefit to a custom knee versus an off-the-shelf knee when replacing?
Also a common question, so I'm glad you asked it. Probably other people have it. I'm going to give you now I said unbiased before on one other subject. I'm going to give you my biased view on this, but I think that a lot of orthopedic surgeons share my view on this. There's one company I'm aware of that makes a custom knee replacement where they actually manufacture the implants for the patient. I don't personally know any surgeons that I trained under or at big joint replacement centers across the country that use it. I think it has no reported advantages, meaning any studies on custom knee implants have not proven to have any benefits. And I think there are actually some downsides in the surgery, because one of the things that we do in the surgery is look directly at the bones and size the implant to the patient, not only based on the size of their bones, but on the soft tissue tension. And we lose the ability to make any changes in the surgery. If we have a custom implant, we can't change the size of the implant. So I think there are actually some downsides. Some of the surgeons that I've talked to that have used custom implants have told me that it ended up in the trash half the time and they had to pull one off the shelf to make the knee replacement work. So I personally am against them. I don't think there's any advantage. I think there are some disadvantages. That's my bias. I think you would find other orthopedic surgeons who would have a different opinion.
Great, thank you. It looks like we answered all the questions. Friendly reminder that this webinar has been recorded and we will be sending out this webinar recording via email by the end of the week. Thank you again to UC Health for giving us this opportunity to learn about hip and knee arthritis from Dr. Koonce. And thank you to all of those who joined us tonight. Our next virtual health event will be on Wednesday, December 9th on Alzheimer awareness. We hope you have a great rest of your night and thanks for joining.